Fibro-osseous lesions are those bone lesions where normal bone is replaced by numerous fibroblasts and collagen with varying degree of dispersed calcifications in the form of immature bone and cementum-like tissue. Among the many fibro-osseous lesions classified in literature, ossifying fibroma is a neoplastic fibro-osseous lesion with proliferative capabilities that exhibits bony expansion. Before we dive into the specifics of the lesion, let us try to understand a few concepts to better comprehend the controversies behind nomenclature and etiology of the lesion. Now, under the microscope, ossifying fibroma shows calcification in the form of bony trabeculae and basophilic spherules, which appear similar to cementum-like material. These spherules of calcification were thought to be cementum-like due to the fact that they appear similar to cementicles. Cementicles are basophilic spherical calcifications that appear in the periodontal ligament and are attached to or sometimes embedded in the cementum. These calcifications are thought to arise from the epithelial rests near the tooth root or from spicules of cementum or bone that get detached due to trauma. Hence, these basophilic spherical calcifications were designated to be cementum or cementum-like tissue. Due to the fact that ossifying fibromas appear exclusively in the jaws and have cementum-like material, their origin was thought to be either odontogenic or from the periodontal ligament. Ossifying fibromas showing only cementum-like calcifications were termed cemento-ossifying fibroma, and those with a mixture of both bony trabeculae and basophilic spherules were termed cemento-ossifying fibroma. However, it is known that certain bone lesions appearing in sites other than the jaw, like in the skull, the facial skeleton, or sometimes the long bones, may also exhibit basophilic cementum-like spherules or calcification. Moreover, pathologists and investigators, in spite of numerous studies, have not been able to distinguish between bone and cemental tissue. There is no sufficient evidence to differentiate them histologically. In fact, most contend the basophilic spherules of calcification to be a variation of bone tissue. Pathologists therefore advise against using the term cementum to describe the spherical basophilic calcifications unless they are in direct contact or attached to the cementum. In such a scenario, the term cemento-ossifying fibroma or cemento-ossifying fibroma becomes confusing. Hence, most pathologists and researchers consider the term ossifying fibroma to more accurately describe the lesion. The etiology of this lesion is unknown, although evidence points to a mutation of HRPT2 gene in select cases of ossifying fibroma. But how this mutation plays a role in causing the lesion remains not very well understood. Most ossifying fibromas are solitary lesions that are well circumscribed. Ossifying fibromas occur in the second through the fourth decades of life with a mean age of 32. These tumors have a female predilection and predominantly occur in the mandible. They are asymptomatic, slow-growing, and may cause displacement of teeth and swelling of the jaws with a lingual or buccal expansion of the cortical plates. Large lesions may also cause swelling of the inferior aspect of the mandible, which is characteristic of ossifying fibroma. They may also at times be small, not causing expansion, and can be diagnosed only through a radiograph. Radiographically ossifying fibroma is a well-circumscribed lesion with sclerotic border. It usually shows a unilocular radiolucency or a mixed radiolucent radioopaque pattern. End stages of the tumor may also show a complete radioopaque lesion. The tumor causes expansion of cortical plates and characteristically may also cause expansion of the inferior border of the mandible. Resorption or displacement of tooth roots may also be seen. Microscopically, ossifying fibroma shows calcifications in the form of bony trabeculae and basophilic spherules in a hypercellular connective tissue with plenty of fibroblasts and dense fibrosis. The stroma is relatively avascular. Bony trabeculae are of woven bone type and are lined by osteoblasts. The basophilic spherules of calcification are usually surrounded by an eosinophilic rim. Now, a tumor called juvenile ossifying fibroma is considered to be a subset in the spectrum of ossifying fibroma, although most pathologists consider it to be a separate clinicopathologic entity that is distinct from ossifying fibroma. Now, this is believed due to the fact that juvenile ossifying fibromas do not show the HRPT2 gene mutation shown by certain ossifying fibromas. And also, these lesions are very aggressive lesions unlike ossifying fibromas. There are two types of juvenile ossifying fibromas, them being the trabecular type and the cementoid type. Juvenile ossifying fibromas occur in the young population and are more rapidly growing and aggressive. The trabecular type occurs more often in the maxilla, while the cementoid type occurs more often in extragnathic sites like the orbit and the paranasal sinuses. As far as the treatment is concerned, complete surgical excision is recommended for ossifying fibroma and is done easily due to the lesion being well circumscribed. Recurrence is rare and the prognosis for ossifying fibroma is very good.